being led by Lindsay. So my name's Charlotte. I'm the project officer working on pins across Cheshire and Merseyside. And just to make sure that you have your microphones turned off so there's no background noise, recording and material and any links to any videos, if need be, will be shared with you after the call. And I will be tracking the attendance for this. So if you could just put in the Teams chat, your names, anybody that you sat with around one computer in the school that you're attending from, we'll be able to keep an accurate log of that. And I'll pass over to you, Lindsay.
Brilliant. So thank you so much for joining today. So for those of you who don't know me, I am Lindsay Boggans. My background is I'm a learning disability nurse, and I've worked in specialist CAMS as an autism and learning disability specialist nurse for many, many years. So over 15 years in specialist CAMS services. And I've always done diagnostic work as well. So I've also, as part of my role, managed some different diagnostic pathways across Cheshire and Mersey. And currently now I am the lead for the diagnostic service at Alderhay NHS Trust. So that is my role. So I'll just share the presentation. And as I say, I have only got one screen, so I'll hopefully take questions at the end. Is that okay? But please do keep your questions or put them in the chat, and then we can go through them as we go along. Okay, so please let me know if there's any problems seeing this. Has that come up?
Yeah, that's up.
Yeah. Okay. Fabulous. So what we're going to discuss today is we're going to look at autism and ADHD, but thinking about it a little bit differently, as obviously they're always the primary sort of neurodevelopmental conditions that we tend to think about when we think of diagnostic assessment. But what I want to do today is talk to you a little bit about what we call differential diagnosis. Obviously, a lot of young children and older young children, they tend to have quite a lot of overlapping difficulties, or there's lots of things that may have happened to them in their life, which may have caused some differences to appear. So what we're going to do is look at neurodiversity, but also look at it, the differential conditions and a few of them in some detail. And we're going to focus mainly on trauma. So children who've experienced ACEs and how that presents in young people. And then we're going to talk a little bit at the end about how autistic young people present trauma a little bit differently and how that feels to them and how we can support them. Okay, so just to start with differential diagnosis. So this slide really just summarises what we have to look at when we do our diagnostic assessment. So when you complete your referrals to us, we generally, as a rule, we have to rule out all other conditions as well when we look at autism diagnosis. So in the actual diagnostic manual for autism, it says, you know, all these differences are not caused by some other condition. So there's a lot of young children who can actually have underlying difficulties. So global developmental delay, you've probably heard of that term used quite often. That's usually given by community paediatricians in the early years setting when children are actually sort of behind in all areas of development. So socially, language development, maybe mobility as well, toileting needs. So they've got a global delay across the board. So intellectual disability or learning disability is when that presents in an older child. So the child may grow up, but they still may have differences in all areas of their development. So not just the social differences or rigidities, but actually everything as a whole. Then we've got ADHD, which I'm sure you're aware of. There's a very, very high crossover between ADHD and autism diagnosis. And a lot of young people tend to get, you know, multiple diagnoses if they present with them differences. And then we've also got the mental health conditions as well, which often I think we forget about when we look at especially older children. If we've got anyone, you know, who has worked with older children who may have got siblings from primary school, they can start to present with depression symptoms and also social anxiety. So the difficulties relating to peers or going out in public, etc., may be due to an underlying mental health disorder. And it's the same obsessional compulsive disorder, you may have heard of it, is around sort of rigidities and routines and having to do things in a certain way, which is a little bit different, which we'll talk a little bit more about. And then we've got trauma. So what we call in CAMS services, we tend to call it ACEs for short. And I'm sure you've probably all done training around that before, but it's just, we're going to revisit that. So, comorbidities. So as I said, a lot of our children, when they come through for diagnostic assessment, they present with various different needs. So that's why a lot of our services are moving towards a model of neurodevelopmental assessment. So being able to assess children for more than one condition at a time, which tries to avoid them going on multiple pathways. So in the general population, at least 40% of children will meet the criteria for one psychiatric disorder. So for example, this is just the general population. So there's 40% of us are going to have some kind of mental health needs throughout our life, whether that be anxiety, depression, anything like that. But that goes up massively higher in the autistic population. So our young people and our young adults, as they grow up, and they're diagnosed autistic, they're very, very likely to develop a mental health condition alongside, so it's 69%. With children with ADHD, anxiety is the most common occurrence in childhood, and it's depression in adults as well. So it's just really to reiterate that there's a lot going on for these young people. Oh, my screen is frozen. Sorry, let me just check. Yeah, I've not skipped ahead. So just to go through them a little bit more detail. So intellectual disability is an assessment where we look at the young person's whole holistic needs. So some of you may have worked alongside education psychologists, and their primary role is to look at the learning needs of a young person. So they tend to focus a lot on verbal processing, memory, etc., sort of language understanding. So they do a lot of what we call psychometric tests that focus on the learning needs specifically. And that can result in some of our children being diagnosed with learning difficulties, and having specific learning difficulties in certain areas around maybe numbers or reading, etc. Whereas a learning disability or intellectual disability tends to be a little bit different than that. So there's more what we do. So within our service, we have clinical psychologists and assistants who will do more of a detailed assessment of the learning needs. So they do look at the cognitive profile and use similar tests to education psychologists, but they'll also look at the social function as well and the impact on that young person. So how are they actually functioning in daily life? Can they manage money? Are they getting on the bus? Are they able to go out independently? Can they get shopping, etc.? So it's looking at that sort of whole person in a holistic way to identify if they've got a global learning disability. So they do tests such as the ABAS-2, which is an assessment of social functioning. And when you piece all of them bits together, so looking at the learning profile, looking at the language profile, and looking at the social profile, we can sometimes say with some of our young people that they actually meet the criteria for a learning disability. Some of you may know that the sort of old sort of data sort of talks about learning disability being an IQ under 70. So we do still use some of them tools to understand IQ, but we also look at the function and impact as well. So some young people may have a higher IQ than that, but still meet the criteria for learning disability services. And there's a lot of work going on to try and cement this really into our assessment process, so that we can actually do this a little bit more often, because there's a lot of children, especially when they get to high school, you know, they may have been really quiet, really shy, really timid, and they may have got all the way through with an undiagnosed learning disability or intellectual disability, whichever term you want to use, which is going to greatly impact on their future. And obviously it's very different to autism, because autism is more around the rigidities, the sensory needs and the social impact, whereas LD is more than that. So ASD and learning disability, so we do have a big overlap. So a lot of our children who are diagnosed autistic will have an accompanying learning disability as well. Often they're picked up in early years. They may have difficulties with language, etc. But we do tend to get them a little bit later as well. So what we want to really do is try and make sure that we can do a coordinated assessment and look at everything sort of as a whole for that child. So similarities that we often see is the language differences that we may see. So there might have been a language delay, social profile, maybe, you know, they may struggle making friends, interacting, etc. And there also might be difficulties in terms of sort of how they relate in terms of conversational style, etc. But there's also significant differences. So, our autistic young people will have the addition of the restricted repetitive type movements and the sensory behaviours, and there also could be difference in motor skills as well. So it's just really to be mindful of that you may have a young person who you think is autistic, but we need to think wider and think, how are they actually getting on in daily life? Do we think this is a global difficulty? Okay, so then we've got ADHD. So ADHD is massively overlapping. So, I mean, I've done some research, and some of the recent research says it can be up to 80% overlapping. I haven't put this in this presentation because it was just one study. But we're looking at about 30 to 50% of young people who are autistic will have some ADHD symptoms as well. So a lot of them will end up being on both pathways at once. So this is why we want to move to a more robust assessment, looking at all of them. And it's a genetic predisposition. So basically, similar sort of, I mean, it's all very scientific, but there's similar, brain differences between the two, parts of the frontal lobe are affected, etc. So there's a very, very, very high overlap of them two conditions. But it's really interesting to be aware as well that a lot of our autistic young people tend to have significant sensory differences. So they may be very, very sensory seeking, they're moving around, they're seeking a lot of movement, etc. And that can sometimes be misunderstood as being ADHD. So this is why the ADHD team do a really in-depth assessment, and they look at that child as a whole as well to see, is it just a sensory difference that we're working on here and what we can see, or are they affected by all the other signs and symptoms of ADHD as well? But we do have that crossover. Okay, so this is just a really, I just find this dead helpful. So I have this up in my office, and it just gives you a bit of an idea of the presentations and what to look for. So we've just got looking at impulsivity, hyperactivity. So these are all the presentations of obviously ADHD that we often see, but there's defined differences. So obviously in the autistic young people, they may be impulsive, but it could be related to the social understanding of the situation, rather than actually the autism, the ADHD profile. Hyperactivity, as I said, it could be a response to the sensory environment. So are they hyperactive because they need to seek movement? If you put in sensory breaks and put in sensory support, will that reduce? And often you can sort of see that difference. Inattention is interesting with children who are autistic because they can often appear uninterested in a topic and appear not to be focused. But that could be because they are hyper focused on something that they're really, really into, or it could be that they just don't want to engage with you because it's not on the interest that they want to talk about. So it's about trying to unpick it and think to yourself, where do we think this is coming from? And often, as Senkos in schools, we don't want you to worry about this as much. This is why we're hoping to put the referral forms together so that you don't have to sort of think, because a lot of the time we get referrals in and you may think one thing and actually it's something else. So we really want to try and sort of support you with that. I think repetitive behaviours is an interesting one because a lot of ADHD children can be very, very active and move around up and down in the seat, shifting their attention, but it's very, very different to the behaviours that we see in an autistic child, which may be flapping, rocking, and all to do with getting that sensory feedback. So it's just really to try and look at that. And then obviously the sensory differences. I mean, the interesting thing is a lot of children with ADHD do have significant sensory differences as well, which makes it even more complicated. And they often benefit from the sensory approach. So what I would probably say is if you've got any concerns and you think that a child who's diagnosed autistic has got a hyperactive profile as well, that's okay to ask for assessment. And, I think what we'd always say is to err on the side of caution so that we don't miss anything, because there is a very high prevalence there. And a lot of the autistic people that I meet and that I work with, when they are diagnosed with ADHD, they can, sometimes go on treatment if they wish to, and, it can make a massive difference for their quality of life and how they perform in the school setting as well. So, sorry, it's a bit of a delay when I press the button. So I'm hoping that this video is going to work. Let me know if you can't hear it.
I can hear it.
Okay, I'm going to stop it there, but you can watch the rest of it. It's just a really, really nice video that just explains, and it's just handy to keep. And also, it's just handy if you're trying to explain to parents as well sometimes, and give them, or even the young people themselves, a sort of, why you're asking for assessment for one or the other. And as I said, it could be that we'd look at both anyway. Okay, so let's move on. Ooh, sorry. So depression. So this is really interesting. We have a lot of young people who come through to us who maybe they may be a little bit older than primary school level, but they tend to be very, very disengaged. So they may have had a lot of difficulties in terms of accessing, social activities or being able to engage in school. And they end up appearing to have no social interest or responsiveness in things. So a lot of these young people who are depressed, some people can think of it as being an autistic profile because they're wondering, why are they not engaged? Why are they not attending events or parties, etc. So it's very, very, very hard sometimes to unpick this. And this is where we bring in our psychiatry colleagues and we work in partnership with our CAMS teams to sort of support these young people and try and understand, because obviously a lot of autistic people, as I mentioned earlier, they will have depression because of what they've been through and how difficult things are in our neurotypical world. So we need to be really careful that we're not dismissing concerns about young people when they start to disengage or they're showing signs of depression. So this little acronym is just really helpful if you want to think about a young person in terms of depression. And often with depression, the symptoms are the sleep is affected. So sleep can be significantly different. The lack of interest in things they may have liked in the past, things that they may have really enjoyed, like going to dancing or, spending time with friends, that might change suddenly. They may feel guilty about, disengagement. They've got low energy levels, low concentration. The appetite can change, so they can either overeat, eat a lot, or they will, refuse to eat. And they just appear really agitated, and they may present with obviously thoughts of self-harm, or they may verbally talk about self-harm. So if you've got a young person who you feel is going through this and it's been a drastic change from how they've been before, then it's worth considering whether there is depression present or low mood. And this is really why I think when we do our assessment for neurodevelopmental conditions, we really dig down into the history of that young person. What were they like when they were little? What were they like in primary school? What were they like? And often some of these differences they may have had all their life. They've always struggled with parties and things, which makes it very different. Whereas a depression profile, they may have a significant change, and they may have been functioning okay and doing really well, and then all of a sudden it's changed. So ASD versus depression. So the similarity is obviously flat effects. So some of our autistic young people, they may struggle with their facial expression. For example, what they would do is they try and mask others around them to try and copy and fit in with our neurotypical world. And sometimes that appears that what we call a flat effect. So not trying to be negative, but it just means that maybe the facial expression is not as congruent. So if something really fun's happened, they may not be displaying that on the face. Autistic children obviously have really difficult sleep disturbance, but often you can dig down and find out that they've had sleep difficulties all their life, and it's always been a difficulty. They may struggle with social situations, and they may have a reduced desire to communicate. So they may just not find conversation with others. That's not what they want, or they find that challenging. And it's just not who they are as a person. So what's different is obviously the onset. So what I said there, often young people who are depressed or struggling with low mood, there's a significant change, and you can often see that quite different approach. It's a tricky one. I mean, I'm not sure if any of you from high school, but some of our young people who go to high school, we will see a change in them because the environment of high school is just so challenging anyway. So their autistic symptoms and profile may start to come out. So obviously we need to be aware of that as well. But one of the other distinguishing features I find that in depression, we don't tend to have the restricted repetitive interest, so that the obsessional interest, they're spending time doing certain activity, and the other sensory differences as well tends to be a little bit different. So there is a way to sort of distinguish. It's just not very easy. So just some stats for you. So ASD and depression. So it says 10% to 50%. So it depends what studies you look at. But there is some research from National Autistic Society that's come out that, it can be up to 50%. So autistic people as a population anyway do struggle with depression because of all of the microaggressions that they face and how difficult it is to sort of navigate the world that they're in. And often it can be difficult for these young people to be supported and treated. So if you've got an autistic young person who you feel is showing these signs, but over and above, they're really, really struggling to access the community, they may have really withdrawn. It could be that they're depressed as well. And then we need to consider how we get them into services. And that's something I'm a real big champion for, is that our CAM services and our mental health services and our counselling services, that they support our young people, even if they are diagnosed autistic or ADHD. That's not the reason for some of these difficulties. And now, you'll be able to be empowered to say, well, actually, I think this young person has got low mood and they need support. Is that okay? So social anxiety. So this is a massive one. And again, the difference between social anxiety and autism is a lot of autistic people, they do have anxiety about going into situations, and especially situations that are unfamiliar, or they don't know people, or the strangers there. And a lot of autistic people cope with this by pre-planning, asking you what's going to happen. They'll read maps and look at visuals, and they really prepare themselves to go to that situation so that they can cope with that. And often our autistic people have struggled with that, through the whole lives, and they've found coping mechanisms to be able to do this. Whereas a young person who is all of a sudden struck by social anxiety, it can be quite a change for that young person's presentation. They may have been outgoing, but something may have happened, or something may have happened to a family member, or even internally they may have just started to worry about things more, and then they become socially anxious and fearful of going out in social situations. So these presentations are very, very similar. And in the section that we look at around friendships and engagement with others, often a lot of children with social anxiety will score very high in the diagnostic criteria in them sections, because they've completely withdrew from, friends and going out and doing things that they used to do. So this is why obviously that history taking is really important, and going right back into the detail. And if you as teachers can do that and try and find out what happened before, it really helps us in terms of the assessment process. So just a little slide for your aid memoir, really. So ASD, obviously young people do struggle with social situations. Some of them don't, some of them are absolutely fine, but some of them will make their own coping mechanisms to make it easier to access social situations. But often children with autism will also have the other concerns. So we're always looking at what we call the Part B, part of the diagnostic criteria. So they'll have strong interests. They'll have, maybe repetitive behaviours, mannerisms that you can see, and there may be sensory concerns as well. So if all that's together with the social differences and the anxiety, then we may be looking at an autism profile. But with the social anxiety, if it's a very, very significant change in behaviour, and obviously if there is the absence of the sensory behaviours and things, and it could be related to exams. We have a lot of kids where they do exams and they can't perform in certain situations, but others that they can. So that would be a social anxiety presentation where our first port of call would be to try and get them some counselling, mental health support, to try and help them maybe do some CBT around that social anxiety. So it's just things to consider when you're looking at your young person and speaking with a family of like, what should we do first? And often, even a child diagnosed with autism can obviously develop social anxiety as well as on top. So by all means, if you feel like it's impacting them and there's been a significant change, they still should be accessing that therapeutic support. So we really, really want to sort of get that message across that if you think they need CAMS or counselling or, anything to manage the actual difficulties they're having, we can get them referrals in for support. So just some stats again. So 50% of children with ASD show clinical levels of social anxiety. And, I think just want to sort of explain that just because you're autistic doesn't mean that you can't have social life and you can't live, and have social, a social life to what you find helpful. So if we've got young people who are not engaging in social activities and who are very withdrawn, we need to try and help them support with that, because it's not, just a given that because you're autistic, you can't have social friends or do anything social. And so we don't want our young people to feel like that. We want to try and help them to get to a position where they feel safe to have some degree of social interaction that they feel comfortable with. And the anxiety obviously amplifies the core symptoms of autism. So if you've got an autistic young person who's also struggling with social anxiety, you may start to see the additional repetitive behaviours, you may see more sensory behaviours, you may also see some sort of outbursts, and some of our young people can really struggle, get themselves into trouble in schools and be seen as quite oppositional, when actually it's all coming from a place of anxiety because they don't feel safe and they feel that the environment around them is too scary for whatever reason. So if we start to understand this, then we can try and help them get to a place where they can manage that a little bit better. And yeah, so just says there about this, there can be often higher levels of aggression. And this is difficult because our autistic young people often don't know how to articulate how they feel. So they don't find the words to be able to say, I'm feeling anxious today. This is the reason why I've got upset. So often, teachers in schools, they just see, the anger, but it's about trying to unpick where that's come from and could it be coming from a place of anxiety. Okay, so I just love this slide. I always put this in when I do training because it's just about just trying to put yourself in the shoes of that young person. They've got so much going on already, and they are impacted by the same mental health conditions that we are as a neurotypical person. And sometimes they can be the symptomology and the impact can be higher. So it's about trying to listen and sitting down and finding out, what's going on. And this is just a little quote from a young person. So I don't have a problem with ASD, just the rest of the world seems to. So that's about our young people just trying to fit into just our normal, neurotypical classroom, trying to get on with the school day when they might need something a little bit different. Okay, so OCD. OCD again is really tricky because in the diagnostic criteria for autism, there is a section around what we call restricted and repetitive routines and rituals. So a lot of young people who are autistic will have routines. So they'll want to get up at a certain time, they'll do things in a certain order. They're very routine around directions they travel, you know, where they want to go. You know, they even notice if you go on a different route in the car, etc. So a lot of our autistic people are very routine like that anyway. Some young people who have a learning disability, they may have behaviours where they'll tap on things or turn the lights on and off, etc. And it's all part of these repetitive patterns that they develop. Early years, we often see this in repetitive play, where they'll play with the same blocks over and over again, or the same toy, and this is how it presents. So we see this a lot in the autistic population. OCD is therefore really hard to figure out with an autistic person, and 30% of autistic young people will also meet the criteria for OCD. And OCD is very, very debilitating. It's really, really hard. I don't know if any of you know anyone who's had OCD, obsessional compulsive disorder, but it can be, you know, it can be life-changing to get them feelings. And OCD, the way it presents itself is the differences, thoughts and cognitions that young person has. So with OCD, they may do a routine, they may turn off the lights on and off, but they're doing it because they don't want someone to get hurt, or they don't want the house to get broken into, or they don't want this car crash. So it's linked to all of these cognitions, which as therapists we have to try and explore and find this out. But autistic people just do it because it's comforting and it makes them feel safe and it's part of their profile. So often when you speak to an autistic person, you might ask them, you know, why are you doing that routine? What's that? It's really interesting. Can you tell me about it? And they'll just say, I'm doing it because I want to do it. And that's absolutely fine. But you might have a young person who's in a routine, who's washing their hands constantly, and they're doing it because they're scared they're going to get sick and they're going to die, or someone else is going to die. That's a different level. That's going into the OCD criteria, where that young person is going to be so impacted by that. So that's where we need to step in and intervene and try and support. And yeah, so again, this is just a little slide. So the repetitive behaviours, again, hand in hand with both conditions, but it's the thoughts and cognitions behind it. So if your young person can't articulate it, that can be really, really difficult. But if they can, sometimes write in diaries, or sometimes doing talking mats or pictures, or you know, like to try and figure out why they're doing that. Also a very interesting one is sometimes to do a bit of an experiment with a young person, that if, for example, I mean, parents, we tend to teach parents to do this, but if they block the young person from doing the routine, what would happen? And sometimes they may articulate that the anxiety goes really, really, really high. So I'm not telling you to do that right now, but sometimes in a safe therapeutic setting, we can sort of test out and think, well, what do they think is going to happen if they don't do that routine? Whereas if it's an autistic person and we've got no concerns about the cognitions, then we really should allow that young person to be their authentic self. So we're not going to put any blocks in, we're not going to stop them doing the routines, we're just going to try and facilitate it so they can do it in a safe way. And that's going to make them feel comfortable and feel regulated, and the sensory differences will be met throughout the day. So yeah, so this is, I mean, I've said this really, but the obsessions that the kids with OCD have are really unwanted. So they're what we call intrusive thoughts. So they basically take over that, you know, the young person's thinking, they can't sleep. You know, I've had examples where young people will be lying in bed and they've had to go down and check all the windows, etc., because the scared someone's breaking the house, and it's repetitive. It goes on and on and on. And they do the compulsions because they're scared of the thoughts, whereas an autistic person will do them just because it's part of who they are and they like doing them. And of course, who are we to stop them doing that? That's absolutely fine. Okay, so we're just going to move on a little bit to trauma as well. So this video is just really, really lovely. And thinking about attachment, so you've probably done loads of training on attachment, so I'm not going to go into loads of detail, but basically attachment theory is around primary caregivers, and it doesn't have to be mom, it can be dad. So as long as there's a primary caregiver in the young person's life, that they grow up to feel secure and that they've got a secure base, and they grow up to have that reciprocal interaction with others. So I'll just put this on for a second so you can see it's just really cute. Oops.
Okay, Buzz, you ready?
I'm gonna stop it because he just lasts for like a good 2 minutes, but it just shows you there, so you can see obviously that dad. So it's a guy out of McFly, I think, but with his little son, he's got that shared engagement. So they're interacting with each other, they're reciprocal. So you can see with that bond between them that they've got a really, really secure attachment, and that that young lad is going to grow up to feel safe and be able to sort of move around and explore the world safely. So you've probably heard of Bowlby. So he was one of the researchers into attachment and that bond. And basically, it talks about young people and kids. They're born with this innate ability to get their needs met from their parents. And if the parent responds appropriately to the needs in terms of interaction, feeding them, getting them to sleep, comforting them, then that young person's blueprint, they will grow up to be secure. And basically it sort of joins them emotionally. So sometimes young people who don't have this obviously can present with differences that we can often get mixed up with the autistic profile. So you may have seen this already, but this is internal working models. So this again is another theory from Bowlby and from Pat Crittenden. So if you've had a positive upbringing and everything has been fine and you've got a loving caregiver, and it doesn't even have to be a birth parent, it can be a foster carer, it can be an auntie, it can be a special guardian, whoever you've got that gives you that support. If you have a positive relationship and your needs are met, you will grow up to have ideas of yourself that you're lovable, you're worthy, and that what you do is effective. And you grow up and you look at other people around you as being available to me, loving, interested, and responsive. So you grow up with a very different idea of the world. Unfortunately, children, when they have had difficulties, so this could be, anything they've gone through, if it's been negative and there's been either a gap or there's been some kind of disrupted difficulty, they can often grow up and have an internal working model that they see themselves as unlovable, unvalued, ineffective, and uninteresting. And this is really sad. And we do have this within the service that I work in. We have young people who've been through, a lot. And other people, to them, they see as neglectful, rejecting, unavailable, and sometimes hostile. So the way they present in the world and the way they are in school and the way they are with peers can be very different depending on their view of themselves and others. So it's just really to consider that when you're thinking about your referrals in. So what affects a secure attachment? And obviously this is not an exhaustive list. There's absolutely millions and millions of different things. And it doesn't mean either that a young person's going to be affected by all of these things. It's got parental mental health on there. So some young women, they may have had significant postnatal depression. Some women have, obviously psychosis and things like that, or they may have to be admitted to hospital. So we're looking at significant differences. It doesn't mean that every mom who's had postnatal depression is going to have affected the child attachment, because it's not guaranteed. It depends on a lot of factors and the intensity of that. But we'd always explore that early life history. We look at pregnancy, birth experiences. We also look at if the child's been unwell or the parent's been unwell, because sometimes gaps from away from each other. If a child's been in hospital for months and months and months and months, then that bond that we've just seen on that video may not be present. So, and mums who've been really poorly in the birth and then they have to be hospitalised, it's all of this. So this is why we get all of that history. Giving birth after a previous miscarriage is really interesting as well, because often mum can be so anxious that she projects a bit of that anxiety onto her child accidentally, because she's scared that she's going to lose that child, so she becomes overprotective and things like that, and then that cycle commences where the child then becomes anxious as well. But this is not an exhausting list. There's absolutely loads. I mean, we've got families that have moved in, from war-torn countries, asylum seekers, etc. So there's so much to consider. Okay, so here's just a list of, some examples, but there's loads of them. So ACEs, what we call them, are when a child has experienced various ACEs, and depending on how much or how long they've been exposed to these, it can affect the child's brain development, and it can sort of affect how they start to think and feel about the world going forward. So exploitation, abandonment, separation, bullying, and obviously it depends on the level. Not every single child is going to be affected by all of this, but some children will have multiple ACEs, and they may have experienced lots of these all at once, which obviously makes them more at risk. So it's just to consider that. So trauma, what is it? So obviously the trauma is an emotional response to an adverse event. So some young children, they obviously can have what we call an overactive trauma response. So if they've been early exposed to trauma in the very early years, they can often become hyper aware and hyper alert. So symptoms can be impulsivity, hyperactivity, distractibility, poor concentration, and racing thoughts. So you can see the overlap already with what we've said about ADHD and what we know about ADHD. Is that sometimes we need to know that history and understand, where is this coming from in the young person? And then the way we class trauma, so there's 3 different ways we classify it. So acute results from a single incident. And this can often happen if a child may have been attacked or has been jumped by, say, a gang of girls or something like that. That's one incident. Yes, the young person's going to have trauma, but that might not be sustained, and it's not going to affect the whole overall well-being of that child. They may have some support and counselling, be able to get over that. So chronic is obviously repeated and prolonged exposure. So this is our families where they may have domestic abuse, or there may be sexual abuse. We've seen some real difficulties, and you may have experienced this yourself, but it's chronic and repeated. And even if this happened, and it's now stopped, the young person's presentation and how they are and how they feel about themselves may still be affected. So we still need to be aware of that. And then we've got complex, which is what we now call complex PTSD, where children have had extreme exposure to traumatic events. So when I was talking about the war-torn countries, we've had young people where they've been, they've seen awful stuff that I just don't even want to repeat really, but they've been through horrendous times. So the way they present in the world is going to be very different. So I'm going to skip this video only because I don't want to run out of time. But please watch it. It's oh no, go on, I'll put it on, but I'll just play it for a bit. So just watch it.
My parents don't understand. All the drinking and fighting means I'm scared. I'd like a cuddle, perhaps a bedtime story, but mostly I'd like them to stop shouting at me, and sometimes they hit me. Feeling scared every day and not feeling loved or wanted will change me for the rest of my life. Later, I'll have problems with school, problems with alcohol, and I'll get in trouble with the police. What's happening to me right now means I'm more likely to have serious health problems in middle age and die sooner than I should.
So I'm going to stop it there, but please feel free to watch the rest. But basically, it's just a video to say that actually ACEs is a massive difficulty in this country, and children who experience ACEs are, the what's the word? Their future and sort of where they're going to be in the future is seriously impacted by that. So in terms of autism and thinking about autism, a lot of the difficulties they may have may be because of their internal working model and how they feel. So, oops, sorry. Oh, sorry, it's just decided it's going to go off. 1 second. Oh, sorry. Yeah, sorry, there we go. So yeah, so recognizing trauma. So for you in school, what we all always want to be aware of is to try and get to know that family as much as you can. If you've got a family coming through for assessment who are asking you to support them, if you can get the developmental history or at least ask a little bit about the social history, it can be really, really helpful, because then it tells us what journey we want to go on. So the severity and duration, the risk factors, always considering, is the risk currently still going on? Is that child still with the perpetrator, etc. Do we need to do anything in terms of safeguarding? And also, what are the protective factors? So we want to really be exploring that. And then noticing an attachment style within a school setting. So it's looking at the child, saying, are they following your lead? Do they initiate interaction? Do they respond to you? Do they respond to emotion? So this is obviously, I mean, I know it's tricky, but this is if you see them with the parent. So if you're doing any work together or you're seeing them together, it's about trying to understand, that relationship between the child. And it's often really difficult to do that. And honestly, we're not expecting you to do all of this. But it's if you've got any concerns that the child, that the parent might not be responding, might not be comforting the young person, might not be, leading them or giving them boundaries, etc., then you may, there may be some concern there that we need to explore. So non-verbal information, often young children with ACEs and trauma, they can struggle with eye contact and really struggle in terms of criticism. So how they accept criticism, often change as well, is really tricky for them. So if you've said you're going to do something, then you're not going to do it, they may get really, really angry. So there's loads and loads of stuff to explore. And as you can see, it all very much overlaps with autism assessment. So there are some things that we do in the diagnostic team to sort of help us with this. So I'll just go through this. So yeah, so when you're with the child, so how does a child communicate their needs to the parent? So how are they telling them? And you're just really looking at, that relationship. How does the parent respond? Who does the child go to? Which sometimes is really interesting as well, because it could be that the child has got a secure attachment to someone else in the family, and maybe it isn't birth mum or birth dad. And again, that's okay, as long as they've got that, that bond. Do they appear relaxed and comforted when they're in the company of the family? And how does the child then react towards the parents? Does the child try to look after the parent? And again, that's a really interesting one, because we have a lot of families where the parents themselves may have, some learning needs. They may have learning disability. They may have some mental health or alcohol misuse problems. So sometimes our kids step in to be the caregivers. But again, that is something that we want to be thinking about and sort of thinking about. So this is a really good slide, I think, for trying to unpick it, just to keep in your office. And it's got obviously trauma on one side. So this is what we'd see in a traumatized child. So often they avoid any reminders of the trauma. So you can often see if it's a caregiver or if it's a gang of girls or whatever, they would try and avoid that, become quite angry, and describe being disassociated, and unusually reckless, aggressive behaviour. So that's trauma. ADHD, obviously, we struggle with attention, instructions, organisation, etc. But the overlap tends to be difficulty concentrating and learning, easily distracted, often doesn't seem to listen, disorganisation, hyperactive, restless, and difficulty sleeping. So it is possible for young people who are traumatised to have ADHD as well. And if you think about how, the diagnostic rate of ADHD, it has gone up. We've got a lot more kids diagnosed with ADHD. So there's a very, very high likelihood that some of them young people will have been through some kind of trauma. So I think in the past, what used to happen was if a child had been through trauma or was open to social care, it was sort of what we call diagnostic overshadowing. So they were put in a box, well, they've got ACEs, so they can't have anything else. Where we now know that that's not true. And actually, they may also have an ADHD presentation. So we need to really try and look at that. And it may be that they get both diagnoses. So this is overlap. So this basically is just talking about the hypervigilance and the alertness for behaviours. And it's just giving you a little bit of detail about, so there's been some studies of the brain for ADHD and ACEs, and it's basically very, very similar, if that makes sense. So it just says, reiterates what I've said, so both can coexist together. So a young person may have ADHD and trauma, and we've developed a lot of pathways now where we're looking at what we call complex and enhanced assessment, where we're actually unpicking and finding young people who have got ADHD who have been traumatized, and we're actually starting to pick that up and treat that now, and it's making a massive difference. So it's just to be aware yourselves of, you know, of just that thinking that it's okay to think if a child has been traumatized and you know that they've had this history, you know, which has been awful, they may have had all the support, but they may still need a neurodevelopmental assessment. So this is just a case study. So this is actually a case where we've got an enhanced support team in Liverpool and Sefton, where we have been trying to work with these complex families. But I'm not going to go through it because I'm conscious I've only got 5 minutes. But basically, the results of the case study was that the young person had been through significant trauma. So I think they'd actually been sexually exploited basically, and there was a lot of county lines stuff going on, and that young person had been moved around for different foster carers, different placements, etc. And there was a lot of high risk behaviour going on with that young person, so much so that people didn't feel they could keep him safe. So what we actually did was we did the ADHD assessment, and he met criteria for all of the, you know, all of the factors as well as the factors for trauma, and he was given a trial of ADHD medication to see if that would help, and it was an absolute amazing difference. And this young person now is actually is being picked to go and play football in America. So his life has dramatically changed from, you know, thinking when we were going to lose him, you know, we thought he was going to get stabbed, we thought he was going to get hurt because of what he was involved in, the gang culture and things in Liverpool. And now he's flying, amazing. And that was because he was treated for ADHD, which had been missed. So, so why is there an overlap? So basically, I mean, I'm not going to go into it in lots of detail. You can read it there, but basically it's just saying that, you know, ADHD, the intrusive thoughts and the memories, it's all the brain that has been affected. It's the same. So a lot of them are, oh, sorry, I think I've done that slide, haven't I? Sorry, ignore me. Right, so ASD versus trauma. So percentage of people diagnosed with sorry, I'm just going to move that out of the way so I can see it. So this is really important to me. So this is something that I really champion, but people who are autistic I've got a higher likelihood of being diagnosed with trauma or ACEs, and they've got increased risk for maltreatment and obviously being involved with crime as well. So they really are, you know, at risk of being experienced ACEs because of what they've been through. And risk factors are obviously the communication differences that they have. So they may struggle in terms of understanding that they're being exploited, like the lad that I was talking about, you know, he didn't know how vulnerable he was and what he was getting himself involved in. And also it's the parent-child relationship, so stress, lack of social support. These families are often really on their own, and you know that there's a lot going on for them. Okay, so this is a really sad list to share with you, but I just wanted you to have the slide. So basically, this is all the symptoms, what we can see in young people for all of these different ACEs. So physical abuse, sexual abuse, domestic violence, psychological abuse and neglect. So you can see there that it is really, really difficult. So all of the problems that these children can have because of what they've been through. But the next slide here is these are the signs and symptoms of autism spectrum disorder as well. So you can see how the overlap sort of is there. So young people who've experienced all these differences can also have autism as well. So what we do within our service is we use something called the Coventry Grid. So I'm not expecting you obviously to do this within schools or anything like that, but it's a free tool. It was developed by Heather Moran in Coventry. And what she did was she found that there was such an overlap that it was making it really difficult for services to understand if it was trauma or if it was autism. So she developed a tool called the Coventry Grid, which has now been turned into an interview. And it helps you to differentiate between all the autism type behaviours and the attachment type behaviours. And we use these as part of our psychology appointments within our service. And it's really, really supportive because it helps actually you to articulate and understand yourself and also the family as well. You can explain back to them. So an example is an autism type behaviour would be if food is restricted by texture or colour. Yeah, so our autistic kids tend to be very rigid about the colour and the texture of the food. Is your child restricted diet about maintaining sameness? So are they eating the same chicken nuggets from the same shop every day? And often that is an autistic behaviour. So you can mark it of what is an autistic behaviour, whereas a behaviour related to food for a child with attachment difficulties would be, is your child hoarding food or binge eating? So are they saving food? Because that could be a survival mechanism for something that's happened to them. So I really urge you to have a little look at this tool and to get yourself familiar with it, because then if you do have young people who come through to your schools, then you can support them as best way you can. So I'm going to skip this because we haven't got time. I'm sorry, I do talk too much. So the Coventry Grid. So I've just put the reference there for you, because I do feel that it's really important to get yourself familiar with it. And on here it says autism and PTSD is really high. So this is just some data again. So the rates of probable PTSD in autistic people is 32 to 45%. And it's 4 times higher than the general population. So autistic people are more likely to experience traumatic events. And if you think about the autistic people, right now, you may have adults or friends who are autistic, or you may have, siblings and things, people in your life, they've probably been through awful experiences, bullying, and the vulnerability of some just makes it really, really, really likely that something's going to happen. So we just need to be aware and make sure we get that diagnosis right. This is just a really lovely slide for you to keep, which is, again, I have this on my wall. It just helps you look at the difference between autism, PTSD, and the overlaps between them, so that you can start to think about it. And again, it might be that they have both conditions, which is absolutely fine. And I think some of us worry that, oh no, it can't be, it's got to be one, it's got to be the other. Well, no, actually, we're looking at the child in a holistic way. And we're looking at them and we're thinking, yes, they've been through all this traumatic experience because of X, Y, and Z, but they've also autistic. And you've got to think about the intergenerational patterns as well, because a lot of our parents might be neurodiverse. They might have undiagnosed neurodivergence. They may have ADHD undiagnosed or autism undiagnosed. So the difficulties that they have in sort of how they're parenting their children, it sort of can pass down through generations. And we found this very interesting where we've assessed, even grandparents, etc., where they're coming through and there's sort of misdiagnosis. So just some statistics for you. So I won't go through it all, but 60% of autistic people have supported PTSD in one study. And it's just really I suppose it's just my way of showing you that we don't want to miss these young people just because they've been through a difficult time, just because there might be domestic violence, just because mum is drinking or dad is drinking, or someone's in prison. They may still have autism, they may still be autistic, and they may still have ADHD. So we still want to assess and be really thorough in our approach to make sure that we don't miss anything. So this video is from Purple Ella, and she is amazing. So she's got a blog, and she's a champion for autism, women and girls, and ADHD. So she's actually got ADHD and autism, and she talks a little bit about her experience of trauma and how that presents. So I'd definitely watch it if you've got some time. It's just really, really interesting to watch it, but I won't play it because I think it's about 5 minutes. So I just wanted to put it in. Okay, so just quickly, because I know I've gone over time, but trauma and autistic people. So autistic people feel trauma in a very different way to us. So neurotypical people can often have what we call resilience, things can bounce off, and that resilience can be very different. But what we know about autistic people is that they are more vulnerable and they can experience trauma in a more intense way as well. So they can actually relive that trauma and feel it within their body. It can be really powerful. So some of the stories you read about autistic people who've been traumatized, they explain trauma in a really different way. So there's often a lot of disassociation, struggles with emotional processing, and it can often be mistaken for drama or attention-seeking behaviour, refusal to comply, refusal to speak, tantrums, etc. But often it's because they may have experienced some kind of trauma, and they still might be experiencing trauma in the classroom right now. Which is what I wanted to explain in terms of what we call microtrauma. So often they'll have a sense of, so microtraumas are differences around in the environment. So for example, anything in the school can make you feel traumatized, that it wouldn't affect us, but it would affect them. And the sensory differences and how they perceive the world can often make it really, really, really difficult and just be more concerning for them. So just some dead simple examples. So fire alarms, fireworks, paperwork, admin tasks. I mean, I went to a conference and there was a lady who was autistic and she was telling me that she just doesn't open her letters at all because even the thought of opening her letters and dealing with bills or dealing with things was actually a trauma. It was causing her to feel actually traumatized. And it can feel as horrible as a bereavement and, as severe as PTSD. Pets is a big one. There's a lot of young people where they've lost a dog or a cat or a rabbit, and it's so traumatizing for them. As much as it would be. So bullying, strangers' comments, all them microaggressions can really, really cause trauma. So yeah, just another visual for you, just to share with families if you wanted to. I just wanted to put it in. And this one as well. So this is autistic traits versus trauma. So it really helps you to sort of unpick it, that sometimes autistic people are still in distress and they may be being traumatized by something in the environment that we can try and change and we can put reasonable adjustments in. So just because they're autistic, they've got their baseline of how they feel as an autistic person, but they can still be affected by trauma and that can still, present and cause heightened symptoms that they don't normally have. So we just want to be really aware of that and mindful. And then just lastly, I wanted to chat about autistic burnout. So this is something that I'm really passionate about. So young people, when they experience micro traumas and they're trying to mask and hold in the difficulties all day, and fit into a neurotypical world, if they do that over a long sustained period of time, then they develop the cortisol levels go high, sky high, all the different chemicals in the brain just go sky high, and then they can get really, really unwell, and they can get to a point where they just can't cope anymore and they completely shut down. And this is what happens sometimes to our high school girls, boys who completely disengage. So if we can help them at the primary level, understand what causes them distress, what are the micro traumas for them, what are the microaggressions that they see, and we can put a plan in to try and support them, then we can try and reduce autistic burnout. So I'm going to stop it there because I've gone on too long. I know I speak more than Hannah, so I'm so sorry, but has everyone got any questions?